everyone, and welcome back to Pain Points. I'm Dr. Jake Caylor. I'm an interventional pain physician here out of Austin, Texas. And the goal of this mini-series, as always, is to try to bring education back to patients to be able to spend more quality time with you and to be able to share some of the things that we utilize every day in terms of making pain diagnoses, as well as kind of trying to advance for our patients the therapies that are out there to treat these pain syndromes. Today, we're going to be talking about defining your pain and what that means specifically when I ask you, tell me about your pain. How would you describe it? Oftentimes, what I get is a number, and that's really not what I'm looking for. And today, I'm trying to explain why the number is one aspect, but there's so much more on the backside that I want to be able to explore. So thanks again for joining me today. We're going to be building off of what we've gone through the last few weeks. So today we're going to talk about the nervous system. Now, I know I've hammered in pain pathways the last couple of weeks, so this is going to be a brief Pain 103 overview. But in general, this is going to be kind of our last stop with the Pain 103, 102, 101 series. And really, we're going to start focusing more on specific pain areas. So this is the nervous system that we'll be talking about briefly today. And we're going to be talking about it in the context of defining pain. And so I'm going to talk about how we as pain physicians define pain. How do we categorize it? And then we're also going to be talking about how do you describe pain? How does a patient, how do your family members describe pain? And why is that really, really important for us? And that's the last thing. Why is it important for us? So thanks again for joining me today. We're going to get started. And then we're going to do a procedure spotlight on medial brain blocks and radiofrequency ablation, like I alluded to last time. So the nervous system, we have a central nervous system and a peripheral nervous system. Now, these nervous systems act in concert. And you'll remember from some of my diagrams last time that the sensory input to the brain goes through the spinal cord. And that's the interaction between the peripheral nervous system and the central nervous system. So the central nervous system is really made up of the brain and the spinal cord. And one of the reasons I want to talk about this is if you have a lesion, and in medicine we say a lesion can be any number of things, but if you have a problem or an injury to the brain or spinal cord, you can have pain, you can have altered sensation, or you can have altered function. We know this from things like strokes, for example, or when the spinal cord becomes pinched. If the spinal cord is pinched and you have spinal stenosis, it might be hard to move the legs or use the extremities. The peripheral nervous system is made up of a couple other subdivisions. The peripheral nervous system has the somatic nervous system, and when I talk about what patients really feel, this is often a somatic input, and those come from spinal nerves and peripheral nerves. And that might be the sensation of a pinprick, or it might be the brushing, the light brushing that you get on your skin. These are sensory impulses that go through peripheral nerves and then are transmitted to the brain. Then we're going to talk about another system called the autonomic system. Classically, this is that fight and flight or rest and digest system, and there's two in there. There's the sympathetic and the parasympathetic. And the interesting thing is, I think we can all understand about the somatic nervous system from the nerves. If you have a pinprick, that hurts. But we also know that the autonomic nervous system plays a role in pain and pain processing. And so that's something that I want to talk about as well. It's a little known and often underappreciated system that plays a role in pain pathogenesis, the creation of pain. And then lastly, the enteric nervous system. This is one of the cool things. The gut has its own nervous system, and that's when we call it the enteric nervous system. It's really the nervous system of the gut, the microbiota, and how all of that plays a role in chronic abdominal pain or visceral pain, for example. So when we talk about the nervous system, it transmits pain and sensation to the brain. It controls what information it receives. Last time I showed you, if the signals go up, there are also signals from the brain that control how much information gets to it. If we didn't, we'd be on sensory overload. So that's one of those pathways we always think about in pain medicine. And the other reason I bring these systems up is it's not just pain that we do. It's other things that we have to take into account. You might come to my office for pain, but like I was talking about last time, there's a lot of different people that are pain doctors, right? An orthopedic surgeon sees patients because of pain. But we need to not think about just pain. We also need to think about all the other things that go into it. So when I ask you all these questions and I'm trying to get to the bottom of how do you describe your pain, I'm really trying to do my job, which is to define the pain. Define the pain. Pain, therefore, represents damage to the body. So it could be arthritis, it could be cut skin, or it could be damage to the nervous system. It can be inflammation, it can be nerve pinching, it could be nerve overactivity, or it could be both. And so these are the things that we need to think about. There's different types of descriptions that match whether the pain is coming from the body or the nerves or a combination of both. So why do we go beyond a pain number? And really, there are classic pain patterns and descriptors. These are things that they might be anecdotal, but they're classic to our training in pain medicine, where we say, okay, the pain starts here and goes here, doesn't go past the knee, stays in the back. We have classic pain patterns that we think about that are associated with certain diseases or pain syndromes, for example. A pain number is extremely subjective. We know for sure that one of the reasons a patient that is in pain rarely says zero when they come into the office is because they're very worried about not being taken seriously. And that's not a conscious thing. It might be a subconscious thing, but that's very fair when we talk about one of the areas in medicine that we failing to actually appreciate the severity of someone's pain experience definitely leads to this very subjective pain number. And so that's why the number for me is not as important as how are we describing it and what are we doing beyond the number. Defining the type of pain helps us to assist in formulating a differential diagnosis. We'll talk about what a differential diagnosis is in a second. And then combining the subjective, that's what you're saying, with the objective, what I'm observing, the data, the evidence, my physical examination, points us towards an answer. And that's what we're trying to do every day when we're listening to you and then doing the examination and trying to put these things together, going over imaging with you. We're trying to put these things together and say, this first thing is the most likely thing causing the issue, but number 2, number 3, number 4, number 5 are also possibilities. And this is how we're going to go about narrowing it down. So how do we define pain on the pain side of things? One of the ways we classify pain is as acute or inflammatory type pain. And this can be these are just examples, acute injury, post-operative pain, or infection, for example. So if it's early, there's a time course here, or if it's described in certain ways, we might say this is an acute or inflammatory type pain. When we get to chronic, we start saying, okay, this is longer than that 6 to 12 week period. The body's given itself time to heal. Why is this pain still here? So that's the temporal or the time relationship. There's some other buckets underneath this, and one of them is neuropathic. And neuropathic pain could embrace the diagnoses of diabetic peripheral neuropathy, post-herpetic neuralgia, for example, or radiculopathy, nerve pain going down the leg. There's certain descriptors for that. So I might describe something as a chronic neuropathic pain, but there's some crossover here, and it's not perfectly definitive. I might say there's elements of acute inflammatory pain as well as a neuropathic phenotype. So both of these things can go towards defining how we say what type of pain the patient's having. And we see mixed. So cancer pain, for example, low back pain is often a mixed picture, and fibromyalgia, which again is this, we'll do a whole segment on fibromyalgia, but it's really an underappreciated diagnosis that's a larger bucket in and of itself. Nociceptive pain, and that's really kind of that somatic type pain that we're talking about. Arthritis, for example, rheumatoid arthritis, musculoskeletal type pains. So all of these things are potential ways of describing pain. And then lastly, visceral pain. And this is that kind of enteric gut type pain from the gut system or from the organs. It's really ill-defined, much more challenging. And that might be IBS or pancreatitis and bladder type pain with interstitial cystitis. So all of these things need to be kind of thought about. So when I'm hearing what the patient's telling me, I'm in my mind trying to figure out, okay, is this a description of inflammatory pain, neuropathic pain, mixed pain, and of the mixed ones, what is it mixed of? Is it nociceptive? Is it visceral? So all of these components can play a role, and there's a goal behind defining this. Defining the pain allows us to categorize and identify what the source of the pain is. It helps us work up the patient and get them going towards necessary treatment. It's completely dependent on the patient. So when I ask, how you describe your pain, and I'm trying to define it, and you give me a number, you can understand now a number doesn't point me down one of these pathways. The number is important because I want to take you seriously, and I want you to know that I understand the suffering that's going on, but how you describe your pain. And the reason I do that every single time with my patients is I'm trying to figure out which bucket are we dealing with more today. In other words, we can't tell you what you feel. We need you to tell us this, which is why we continue to hammer this home. So one of the things that's important in medicine is not just figuring out pain, but it's figuring out all of the things that go with the pain. And there's this interesting thing called a mnemonic. This is just one I Googled online. It's called Old Carts, but basically it's defining the pain not just as a description, but where does it start? Where does it go? How long does it last? What makes it better? What makes it worse? What time of the day does it have? How severe is it? All of these things, what we're trying to do is help guide us towards a particular diagnosis or away from one, for example. So the subjective patient experience is critical in doing our job and being able to figure out where the pain is coming from or the other sensations that go on. And so the symptoms that you're experiencing helps us define that further. And as you can see, it's really not just pain that we're interested in. Everything else is important too. If there's weakness, if there's numbness, when we talk about the subjective aspect of things, what is the amount of suffering that goes on, right? Because pain is one component, but suffering is another. And so we want to define all these aspects of the pain to be able to know not only what's the most likely diagnosis, but what's a therapy a treatment that might benefit that. We need to know about all the other aspects of the pain to be able to get to that diagnosis. So this is the history of the present illness. This is something we are tasked with every time when we're seeing a patient and writing a note to try to figure out, okay, where are we going for this patient? There are many different descriptors of pain, and these descriptors of pain have kind of classic leanings where it might take you towards a neuropathic or a nociceptive description. These aren't perfect, but they're ways that we think about a certain definition of pain. So when I ask you, get very real with me in terms of what does it feel? Is it someone that's standing there with a hot poker pushing it into your spine? Is it someone that's squeezing you and just never letting go? That's something that is very, very helpful for us in being able to target the pain. Putting it together, we have the subjective, that's what you're telling us. All right, that's the story. We have the objective, that's our examination, that's our labs, that's really like everything that we're trying to put together that we call data. And what we're trying to do is figure out what is the differential diagnosis. What is the most likely cause? But after the most likely cause, what is the second most likely, third most likely, and so on and so forth. And the goal is to create this list of possible things it is. And again, I'll go back to what I said on the very first day. Pain is very complicated. There are layers to pain. By the time you see us, the pain has become something that it wasn't initially. And so we have to do all of this, go through these motions to really figure out what is the root cause of the pain and how have all of these altered biomechanics changed your experience. So that's what we're doing when we're pushing you through trying to ask all these things. And that's why we can be wrong, because pain is not so easy. If there were a painometer, I tell patients this all the time. If there were a painometer, I would be out of a diagnostician's job, and that would be a wonderful thing because then I could just treat. But this is the art of medicine, is being able to take these things and actually say this is the most likely diagnosis, but this could also be playing a role, or maybe it's these two things together. All right. Today we're going to talk about the facet joint. So we talked kind of about this last time. These are real joints. These are diarthrodial joints, meaning they have a synovium and a capsule and are an articular surface. And the interesting thing is, look at the intervertebral disc. That's the front of the spine. I don't know if my cursor shows up here, but the front of the spine, oh, it does. It's over the disc right now. The front of the spine bears the weight of the spine. And you can see that these discs and these vertebral bodies are oriented horizontally. And these horizontal orientation is great for holding stuff up. That's why Greek columns are all stacked up on top of each other. Look at these facet joints. These guys in the back, the facet joints are oriented more vertical. And that's why they're better at rotational stability as we bend and twist and turn. And so these things together are really important when we're trying to figure out where the pain is coming from, trying to figure out, is it more front of the spine or back of the spine? These facet joints, when the front of the spine actually wears down, puts more pressure on the back of the spine. And so we can do facet joint treatments to try to treat them. And so the back of the spine, like I said before, bears less weight of the spine. They're really important in stabilizing the spine from forces of rotating, bending, twisting. And like I said, I know the slides too well. The front of the spine degenerates, the back of the spine bears the weight. It leads to advanced arthritis and pain. So one of the things that we can do is this thing called a medial branch block. And this is a test. And the medial branch nerves are these tiny little nerves that sit over on the transverse process, and they actually supply the pain sensation to the facet joint. So when we're doing treatments for the facets, we can either go into the joint and treat the joint, or we can treat the nerves that go to the joint. We put a small amount of numbing medicine on these nerves if we think they could be causing pain. And if you get excellent short-term relief, then we can come back and use a special needle to actually burn these nerves. That process is called radiofrequency ablation. It's technically thermocoagulation, where we're using a special amount of electricity to heat that nerve. The nerves regrow, however, and so that burning may need to be repeated. And it depends how fast your nerves grow, how often you need to repeat that burning. So prior to burning, the insurance companies require that we do 2 test blocks. This is an insurance requirement. It's not what we want to do. So we have to do 2 test blocks that are spaced 2 weeks apart. If they both are great relief, 80 to 100% relief, then we can proceed and actually burn these nerves. Once you have these nerves burned and it works, you don't have to repeat the blocks unless it's been a long time since you've had that initial procedure. All right. And then here's actually what it looks like on X-ray. And you can see here you have 3 needles that are coming down. They're on that transverse process. Here's the superior articular process. And these are actually those special needles, and they have a wire that goes through them to conduct that electricity. And this is 3 areas of the L3, 4, 5 medial branch nerves that go to these facet joints of the lower spine. If you have any questions, we can take questions now. I know I've run long. Going forward, these are going to start getting a little bit shorter, and that's because we've done a lot of the teaching in terms of the anatomical pathways, and now we're going to have a little bit more fun with actually looking at isolated areas like low back pain and neck pain and different options for different types of pathologies. Down the road, we're also going to do things like spinal cord stimulation, intrathecal drug delivery, pain pumps, which is one of my areas that I love because it's a home run therapy for patients. So I'll take questions now if we have any, but I know I've run long as always. And join us next week. I think last time I put the wrong date on it. So next week, we're really talking about peeling away the layers of pain and dysfunction, because it's not just about pain. That's not all we do. We also are trying to figure out, why does it feel different? And why is there weakness? Why are there other sensations that go along with it? So thank you guys so much for joining me this week, and I look forward to seeing you next week.